Welcome everyone to the 8th CITF seminar series event, the Omicron tsunami. My name is Dr. Catherine Hankins, co-chair of the COVID-19 Immunity Task Force, and I'll be your moderator today. Before we get started, I've been asked to share some instructions as we're providing simultaneous translation into French, and we'll have a bilingual question and answer period. Bienvenue à tous.
Welcome everyone to the 8th CITF seminar series event, the Omicron tsunami. My name is Dr. Catherine Hankins, co-chair of the COVID-19 Immunity Task Force, and I will be your moderator today. Before we get started, I've been asked to share some instructions as we are providing simultaneous translation into French, and we'll have a bilingual question and answer period.
At the bottom of your Zoom screen, you will see an icon of a globe. Choose off if you are bilingual and want to only hear the live feed. English attendees, you should select the English option so that you can hear the entire event in English. The presentations will be in English, but the question and answer period will be bilingual. When questions are asked in French, our panelists will answer in French, if a French-speaking panelist can answer that question. Au bas de votre écran.
At the bottom of your Zoom screen, you will see an icon of a globe. Choose off if you are bilingual and want to only hear the live feed. French attendees, you should select the French option so you can hear the entire event in French. The presentation will be in English, but the question and answer period will be bilingual. When questions are asked in French, our panelists will answer in French, if a French-speaking panelist can answer the question. Please go ahead and select your language preference now.
Select your language preference now. I want to start by introducing the speakers joining me today to talk about the results, mostly from task force funded studies. David Buckridge is the scientific lead data management and analysis at the COVID-19 Immunity Task Force. He's a professor in the School of Population and Global Health at McGill University. Harriet Ware is a data scientist at the University of Toronto, and she's speaking on behalf of the task force funded Zero Tracker. Ciro Piccirillo is a professor of microbiology and immunology at McGill University. He's also a task force funded researcher. And Michael Grant is professor of immunology and associate dean of biomedical sciences at Memorial University of Newfoundland. He's also a task force funded researcher. The COVID-19 Immunity Task Force was established by the Government of Canada in April 2020. Seems like eons ago, really. Its mandate is to catalyze, support, fund, and harmonize knowledge on SARS-CoV-2 immunity for federal, provincial, and territorial decision makers to inform their efforts to protect Canadians and minimize the impact of the COVID-19 pandemic. We currently fund 113 studies across Canada. And as you can see, we have studies active in every province and territory. The topic today is the Omicron tsunami. But why are we using the term tsunami? I'll ask Dr. David Buckridge to answer that by sharing data showing just how many Canadians have been affected by Omicron. Dr. Buckridge.
Thank you very much, Dr. Hankins. It's been my pleasure. So as the slide shows, I have no conflicts of interest to declare in relation to this work. And I'd like to start out by telling you a little bit about why we've used serology data in this context, or perhaps more appropriate, the value of serology data to really look at the size of this wave, as Dr. Hankins described it. As many of you know, when the new variant, the Omicron variant, arrived in North America and in Canada, as it happened elsewhere in the world, the number of people infected increased so quickly that it really overwhelmed the capacity of our laboratory testing for SARS-CoV-2 that was operated by the different provinces and territories in Canada. And that was really important from our ability, for our ability to track the size of the pandemic and the number of people affected or infected, because we were usually in many situations relying on the clinical testing data to give us a sense of how many people are becoming infected. But of course, once we had more people being infected than the testing system had capacity to test, those two stopped tracking each other, and the testing data on its own became less useful for really understanding how many people are being infected. And unfortunately, we saw a similar pattern in other types of data too, even in hospitalizations, for example, which tend to be for more severe cases of COVID-19. Because so many people are being infected with Omicron, almost half of the people who are hospitalized in many provinces were not actually admitted to the hospital primarily for Omicron, or for COVID. They were admitted for other conditions like childbirth, for example, or a traffic accident or injury, and were only found to be what we call incidentally infected afterwards. So just to say, the usual metrics that were often relied upon to keep track of how many people were being infected within the pandemic became harder, if not impossible, to interpret in the Omicron era. Fortunately, we have put a fair bit of effort through the task force, as others have around the world, into monitoring serology, or the response of people in terms of their antibodies in their blood and how they respond to either infection or vaccination. And these data are not really impacted so much by the factors that really made it hard to interpret laboratory data. And particularly in Canada, what's exciting or interesting in this regard is that the way your immune system reacts is slightly different to an infection as it is to if you're vaccinated with one of the vaccines available in Canada. And so by looking at a particular type of antibody reaction called the antibodies to the nucleocapsid, or the sort of membrane enveloping the virus, we can try to distinguish or separate people who have become have immune reaction to an infection versus an immune reaction to a vaccination. And so by following this change in what's called anti-nucleocapsid serology, it gives us a window onto how many people are being infected over a relatively short period. And we can making certain assumptions, we can use that to try to estimate as well the number of new infections. And so this really builds on work that the task force has been doing, as Dr. Hankins mentioned, to fund multiple studies around the country and try to work with those investigators to centralize and harmonize their serology estimates so we can do this type of analysis. And so I can show you some of those results now. And I think we look at the big picture here. Let me just orient you to the slide that I'm showing you. Along the horizontal axis at the bottom is the date. And so we're covering the whole period of the pandemic here. On the Y, or the vertical axis going up, this is seroprevalence. So this is really the proportion of people in a study that were found to have those anti-nucleocapsid antibodies that I mentioned that suggest they've developed immunity through infection. Okay, so we're looking here at immunity developed through infection, and this separates out the people that have immunity from vaccination. And so that's the orientation of the plot here. And then we divide the plot into three sections. The first section is the pre-Delta era, which is sort of the original, some of the earlier variants of SARS-CoV-2, and then the Delta era, and then at the end, the Omicron era on the far right. And we're showing you a number of dots. The size of the dot is corresponding to the sample size. So how many people were sampled? And of course, the more people you sample, the more confidence you have in some sense in that estimate. And you can see some estimates or some indication of the size of the sample on the right. And the color tells you the region of the country that sample came from. So obviously, when you look at that picture, and then we've actually fit now a curve as well to try and look at what's the sort of the general tendency of all these points when you look at the big picture. And you can tell just from looking at this plot that we had quite a significant increase in seroprevalence in the Omicron era. And in fact, if we look between August 2021 and May 15th, 2022, we go from a low of 2% in August of 2021 up to a high of 40% after 5 months of the Omicron wave at the end of May, or May 15th, 2022. We can even look at this in terms of average monthly increases. And of course, you can see a very slow increase in the pre-Delta era, where we're going up at around 0.3% per month. In Delta era, it slowed down even more. It was around a 0.18% increase, so relatively slow. And then in that last Omicron era, we were climbing at the rate of 9% in terms of increase in seroprevalence. Now, as I mentioned, we can try and convert this, especially in the Omicron era, over short periods of time. That change in anti-nucleocapsid serology almost directly can be assumed to correspond to number of infections. And we look at that fitted curve in the Omicron era, and we try to say, well, what's the slope? Can we estimate those number of infections? We come up with a number or an estimate that's about 15.6 million people in Canada were infected over that interval during the Omicron era. And our estimates range that could be as low as 13.6, as high as 17.7. But nonetheless, a very large number of people in Canada were infected, we believe, during that Omicron era. Now, we can also look at these data in terms of regional estimates a little more carefully. So here, it's perhaps easier to see the difference between regions when you break it out into these three plots. And so these plots I'm showing you are exactly the same in terms of their layout as that large plot on the previous page. We just have now three panels, one for the Western provinces and territories, one in the center for Ontario, Quebec, and one on the right for Atlantic provinces. Again, the size of the circle indicates the sample size, but now the color of the circle is showing you the type of study that generated these results. As you can see, the majority of our estimates come from blood operators. That's the Canadian Blood Services and HEMA Quebec, and those are the red circles. You can also see some provincial and territorial surveys, which are done by provinces and territorial public health organizations in blue, and then research cohorts are in green. Now, what you can see here quite clearly is that the highest levels of seroprevalence, which, as I mentioned, correspond to these increases correspond to numbers of infections fairly well, is in the Western provinces and territories, where we see seropositivity due to infection range from 44% in British Columbia to a high of 55% in Alberta. In the other provinces in Ontario and Quebec, we see a similar increase with seropositivity rising to 46% in Ontario by mid-May and 27% in Quebec from the last week of March, which is where we had the last data point for Quebec. Atlantic Canada, which, as you can see in the pre-Omicron era, had very low levels of seroprevalence to anti-nucleocapsid antibodies, suggesting low numbers of infections, really has increased quite dramatically, in the Omicron era, up to just over 40%. And so they've almost become some more or less equivalent at some level to, or a similar area to where certainly Ontario and Quebec and other areas of Canada are. Now, we can also look at this breakdown by age groups, which we have on the following slide here. And so again, the layout is exactly the same in terms of the way the plot's laid out here, and the circles still indicate now the size of the sample, but what we're showing you now are the color is indicating the median age of the sample. So lower ages are shown in the lighter, closer to blue or gray colors, higher ages in the darker reddish colors. And you can see, of course, that in the Omicron era, all ages were certainly affected. And again, most of these data are for blood donors. So we have to be a little careful because we don't tend to have a lot of younger age groups or children. In fact, we don't have any children in blood donors. So we're really looking here at sort of, I would say, teen or older teens into the rest of the age distribution. But the highest level of infections we're seeing is certainly in young adults, with about a 65% seropositivity in the second week of May. And these rates of seropositivity, then, as you can see on the plot, decrease with increasing age. So once we look at the 25 to 39s, it's down to 56%, and the 40 to 59s, 47%, and for the 60 plus, it's down to 29%. So as I mentioned, although children are not included in most of the Canadian sero surveys, certainly there are some of these provincial sero surveys that are using residual blood that have found estimates of seroprevalence in younger Canadians, children aged 1 to 9, for example, having seroprevalence in Manitoba around 47%, and 52% of children who are adolescents aged 10 to 19% also being seropositive in March. So I think this gives you a pretty good picture then of the overall increase that we showed on that first slide, that geographic distribution and the age groups. The bottom line is there's been a really quite considerable increase in the number of people with this anti-nucleocapsid antibody during the Omicron era. and that corresponds to a very large number of people infected, as I mentioned. And I will pass it back to Dr. Hankins.
Thank you, Dr. Buckridge. I hope you're convinced now that this really was a tsunami. So Dr. Buckridge has shown an estimate of the number of Canadians affected, but there's a common misconception that Omicron only brought mild cold-like symptoms and that getting Omicron wasn't a big deal. Statistics from both the Public Health Agency of Canada and Statistics Canada suggest that this is not the case. Although many, if not most, did get mild symptoms, tens of thousands were sent to hospital in serious condition and needing to be placed in the intensive care unit, the ICU, during the Omicron wave. These data show all ICU admissions, so not all are necessarily directly caused by COVID-19, as Dr. Buckridge pointed out, but the trend does suggest some sort of a causal relationship. In addition, thousands of Canadians died from Omicron, about as many as died in 2 of the previous waves. These data from the Public Health Agency of Canada show deaths due to COVID-19. Another truth about Omicron, younger Canadians experienced high excess mortality during Omicron. According to new data from Statistics Canada, for those under 45, there were 15.6% more deaths than expected in January 2022. Now, I'd like to ask Harriet Ware from the task force funded Zero Tracker to tell us more about the effects of Omicron globally. Ms. Ware, the floor is yours.
Thank you, Dr. Hankins. So I also have no conflicts of interest to declare. So I will be speaking on behalf of work conducted jointly by Zero Tracker and the World Health Organization. So at Zero Tracker, we are a CITF-supported data and dashboard platform that tracks and synthesizes SARS-CoV-2 seroprevalence studies worldwide on our website, zerotracker.com. And for this analysis, we identified general population serosurveys rated low or moderate risk of bias globally, sampling people between 2020 and 2022. This was over 800 studies. And we used these to track the progression of seroprevalence over time. So basically, we calculated monthly overall, so from infection or vaccination, seroprevalence, as well as infection-acquired seroprevalence using meta-analysis by country and by WHO region. We also calculated the ratio between infection-acquired seroprevalence and the incidence of reported cases to get a sense of the undercounting of cases. Due to the delays in releasing serosurvey results and publications, we have Omicron era estimates available in only 4 regions, so I'll be speaking about those now. So first, in Africa, so in these graphs, the blue line represents overall seroprevalence and the red line infection-acquired antibodies. So in Africa, as you see from the lines being very close together, most of the increases in seroprevalence over time were driven by infections. The level of infection-acquired antibodies was already quite high at the start of vaccination, and then continued to increase further through the start of Omicron to around 63%, and has likely increased significantly further since then. This region also had very high case under ascertainment. So we estimate that for every reported case, over 100 infections were undetected. So by contrast, in the Western Pacific on the next slide, as you see from the blue line, most of the increases in seroprevalence here were driven by vaccination, and the level of infection-acquired immunity was very low just before the start of Omicron, so around 4%. And this can help explain the post-Omicron picture that we saw in this region in terms of the rapid increases in severe disease in places like Hong Kong, presumably reflecting the combination of their zero COVID strategy that led to this very low infection rate, combined with a failure to adequately vaccinate vulnerable groups. So then moving on to the Americas. So this is high income countries only. In this region, we see increases in seroprevalence driven by both vaccination and infection. Pre-Omicron, primarily vaccination, and but as we saw in the last presentation, also sharp increases in infection during Omicron, up to a level of around 55% infection-acquired seroprevalence in March of this year. And because these estimates are population weighted by country, this reflects the US more so than Canada. So finally, looking at Europe, also high income countries only, which is where we have data. So this is a similar picture to the previous slide where seroprevalence was driven by both vaccination and infection, primarily vaccination in 2021, but then also increases in the red line of infection during 2022. And in March of this year in the European countries, approximately nearly half of the population had some infection-acquired antibodies. This region also had the lowest case under ascertainment. So, but still for every reported case, there were about 2 undetected infections. And then finally, just want to acknowledge the study team. So all of the individuals, researchers, and partners conducting studies, the WHO and WHO partners, and the full Sero Tracker team and Sero Tracker partners, including the Public Health Agency of Canada, the CITF, the Robert Koch Institute, and the Canadian Medical Association. Thank you. Back to you, Dr. Hankins.
Thank you, Ms. Ware. You are certainly highlighting massive regional differences in access to vaccines and in case ascertainment. That was a really interesting presentation. So why did Omicron manage to infect so many vaccinated people in Canada and around the world? To answer that question, I'm going to turn over to Dr. Ciro Piccirillo. Dr. Piccirillo.
Thank you very much, Dr. Hankins, and good morning to everyone. Next slide. I too have no conflicts of interest to declare related to this study. Now, we all know the central role of the immune system in fighting infections and controlling infections. And in fact, there are a number of very important immune cell types that need to have a high level of teamwork to achieve that control of infection. In a typical infection, as you can see on your far left, we have our initial line of defense, which we refer to as the innate immune response, followed by a progressive evolution increase in the contribution of adaptive immune responses contributed to by T cells and antibodies. Let's take the case of COVID-19 as SARS-CoV-2 infection. In a primary infection, when individuals are exposed for the first time and we inhale the virus, the initial adaptive immune response is really procured by important mediators. First, B cells that produce immunoglobulin or virus-specific antibodies. These antibodies have multiple roles, but their most important role is that of viral neutralization in entry into human cells. We also have the activation of CD8 T cells, which we refer to as killer T cells. And these are cells that have the capacity and the mission to kill virus-infected cells in the host. And lastly, we have another category of white blood cell, a CD4 positive T cell, a helper T cell that really is an important orchestrator, a master orchestrator of this immune response. And they help B cells make antibodies, and they also help CD8 T cells in that killing response. Importantly, once we recover from infection, once we are reinfected, or the immune protection conferred by vaccination, we now have a state of immune memory where our immune system now can recall the response very specifically, very rapidly, very efficiently. If you can click. Importantly, as we consider variants of concern, viral variants that emerged throughout the pandemic, each one endowed with its pool of mutations, these mutations have the capacity, the potential of altering the functions of antibodies and T cells in their capacity to react and respond in laser-specific precision in their recognition of viral components for their eventual eradication. So we then ask, well, how exactly does Omicron escape our immune system? You can see here in the center of the slide a multicolored three-dimensional rendition of what the spike protein looks like for Omicron. Importantly, Omicron is known for harboring many, many different mutations. These mutations can affect Omicron behavior in two ways. On your left, the first is to increase its capacity to infect by allowing it to bind much better to the human receptor ACE2, and also to reduce the level of viral fusion, thus reducing the level of severe disease. On the right, many of these mutations actually alter the capacity of antibodies to recognize them and to bind to them. And so a lot of these mutations have the capacity of escaping immunity. And Omicron has mutations that make it look different from previous variants, allowing Omicron to become a bit more stealth-like and living under the radar. Next slide. Our team at McGill University has sought to understand what is the footprint of an antibody, of a protective antibody. That is, what components of the virus do the antibodies bind? What are those epitopes? And does that binding potential differ between an individual that never saw the virus in blue versus an individual that was infected? And we then ask whether these are affected by Omicron. And how do we do this? Well, we exploited a technology known as high-density peptide arrays, which basically consisted of it taking the entire universe of proteins of the SARS-CoV-2 virus, fragments, which we refer to as peptides, and then we layer on that serum from a drop of blood of patients and ask whether the antibodies of those patients are capable of binding to, well, in different affinities, to any one of those epitopes. And we've discovered that the binding footprint of a positive patient is rather different from a negative patient, and that is expected. Next slide. But importantly, when looking at our epitope signature, the footprints of individuals that see SARS-CoV-2, we've discovered that variants of concern in general, here depicted on the left, is far more enriched in epitopes that are harboring mutations. In other words, mutations have a higher likelihood of being targeted by mutations from an emerging variants of concern. But very importantly, as indicated by the plot on the far right, you'll notice that if you can take a look at Omicron relative to any other virus that precedes it, you find that the number of possible escape mutations is significantly higher in Omicron than it is in other viruses, particularly in the spike protein. Thus, Omicron has many more mutations, which provide it with the potential of evading immune protection. Next slide. So if we then ask on the T cell side, we know about the antibodies. What about the T cells? Well, we can take blood from patients and then stimulate them in vitro with peptides that derive from the traditional spike relative to the Omicron spike, and examine them through a technique known as flow cytometry. And we can do this for CD4 cells, we could do these for the killer cells, and then depending on the spread of that population on the y-axis or on the towards upwards or towards the right, we can determine the extent to which those T cells are capable of binding. Next slide. And as you can see here, as we compare T cells from an individual that received 3 boosters versus those that got a double booster plus an Omicron infection in light blue, we can see that people with Omicron generally respond rather well in terms of T cell responses. This is true for both helpers, it's true for both killers as well. And the Omicron response is actually quite equivalent, despite the fact that antibody responses may be different. Next slide. And so what is emerging from our studies, that we're currently examining whether the age of the individual, the immune status of that individual can actually favor the emergence of a variant with the potential of escaping immune control. And this is done through sequencing the virus genome, as well as mapping the footprint of these epitopes. Lastly, members of our team here in McGill, across the country and around the world, and our funders. Thank you very much.
Thank you very much, Dr. Piccirillo. This is fascinating. And to look at the kind of response you're suggesting from Omicron after 2 vaccines, that leads us actually right into our next talk. With millions of Canadians and people globally now having had both vaccines and an infection, I'll ask Dr. Michael Grant to explain his findings about what we call hybrid immunity. So the immunity that people have due to both vaccinations and infections. Dr. Grant.
Thank you, Dr. Hankins, and good afternoon, everyone from Newfoundland. I have no conflicts of interest to declare related to this study. I'm first going to introduce our study cohort to illustrate what groups we were able to compare and at what stages of their vaccination and/or infection history. We enrolled 50 individuals who were infected in the early waves of COVID, and then expanded our study up to over 500 participants who've since been vaccinated 1, 2, or 3 times. Of those vaccinated, at least 47 have so far contracted Omicron, and some of those after 2 vaccine doses and some of them after 3 vaccine doses. There's also a few now who were infected in the original waves who have now been reinfected with Omicron. We take blood samples every 3 months to measure infection and/or vaccine-induced antibody responses against spike. And we monitor antibody responses against nucleoprotein to detect new infections. We also collect peripheral blood lymphocytes at each study point to study cellular responses induced by vaccination and infection. When we compare anti-spike antibody levels on the next slide in people only vaccinated to the levels in people who were previously infected, there's a clear difference. Antibodies persist up to a year after infection at around levels induced by a single vaccination. And after a single vaccination, they increase above the levels induced by 2 vaccinations in naive individuals. On the right-hand side, when we look at an age and sex-matched comparison group, there's a significantly and strikingly higher level of anti-spike antibodies after 1 vaccination in the previously infected or hybrid immunity group, as we now call them. There was only a marginal increase in anti-spike antibody levels induced by a 2nd vaccination in the hybrid group or by the 3rd vaccination in the vaccination-only group. If we then split the previously infected group into subgroups based on the severity of their infection, on the next slide, we can see that the subjects with more severe infection clearly had higher levels of anti-spike antibodies. So this difference was evident after recovery from infection, and it persisted after the first vaccine dose and persists after the second vaccine dose, even though there's not much of a boost from the second vaccine dose in this group. When we look at the neutralizing capacity of the antibodies from the people recovered from infection, those recovered from moderate to severe infection have higher levels of functional activity neutralizing the virus. And these levels are boosted in both groups by vaccination, the levels of neutralization, but they remain higher in the group that suffered more severe or moderate or more severe infection. So more severe infection produces both higher levels of antibodies, and these antibodies have higher, greater functional activity. We look at T cell responses. Moderate to severe infection also induces a stronger T cell response. On the next slide. So this T cell response is significantly boosted by one vaccination, but not again boosted by a second vaccination, similar to the antibody response. What I believe is very important on the far right in the purple squares, we see that severe infection, there's selective development of a very specialized subset of memory T cells in this group. These cells make multiple cytokines. We call them polyfunctional T cells. And when they're exposed to SARS-CoV-2, they're long-lived. They're able to proliferate to high levels, and they're poised to become fully competent killer T cells, as were mentioned in the previous talk. These are a type of cell which can clear viruses from people by killing infected cells directly. On this next summary slide, to summarize what we've learned so far about hybrid immunity from vaccination following infection, you get higher levels of anti-spike antibodies and a greater ability to neutralize viral infection than those who've never been infected. You also get a higher level of something called antibody-dependent cell-mediated cytotoxicity. I didn't show the data for this, but this is very important as it's less sensitive than neutralization to variation between the ancestral and the newer strains of SARS-CoV-2. You get a stronger T cell response when the original infection is more severe, and this severity drives maturation of T cells into long-term memory cells that can rapidly acquire killer functions. These cellular responses of the killer cells are also less sensitive to viral variation than are the neutralizing antibodies. Moving on to the Omicron tsunami, we're now dealing with a high number of infections that occurred following vaccination. And there's also now a bigger difference between the vaccine-related and infection-related spike antigens. Infection with Omicron significantly boosts the levels of anti-spike antibodies after 2 vaccinations, as shown on the left-hand graph. And it boosts it to a level almost equivalent to what happens with a third vaccination. When people who acquired Omicron after 3 vaccinations, there was not a significant, there was a low-level boost of antibodies against spike, but it was not significant. And another thing that is important is that in each case with Omicron infection, regardless of whether people have been vaccinated 2 times or 3 times, the antibodies remained selectively specific for the vaccine strain or the original ancestral Wuhan strain of spike. And they did recognize the Omicron spike, but to a lesser extent than they recognized the Wuhan spike. And this preferential binding to the Wuhan spike or the ancestral spike vaccine spike protein was always maintained in persons infected with Omicron. We were very curious to find out if this pattern was mirrored in unvaccinated people who did get infected with Omicron. We look at T cell responses in people infected with Omicron after vaccination. On the next slide, the anti-spike responses induced by vaccination aren't significantly boosted by Omicron infection. But Omicron infection does induce de novo T cell responses against the nucleoprotein of of SARS-CoV-2. So nucleoprotein is not included in the vaccine. So these are de novo responses induced by Omicron infection. So Omicron infection is immunogenic, but it doesn't elevate the anti-spike T cell responses over those already elicited by 2 or 3 doses of vaccine. And infection doesn't result in selective recognition of the Omicron spike protein. To summarize the second part of this presentation, Omicron infection boosts anti-spike antibody levels after 2 vaccine doses to a similar extent as a 3rd vaccine dose. New T cell responses against nucleoprotein are induced by Omicron infection, but the vaccine-induced anti-spike T cell responses aren't boosted. Similarly, there are early reports that those persons previously infected in earlier waves do not receive an immune boost from Omicron infection. So there's still a lot to learn from this, from studying hybrid immunity due to Omicron infection. But one thing that I think is clear is it's not automatically better for your immune response. More vaccination or more infection is not automatically better for your immune response. And there will be some value in being strategic about the vaccine nature, timing, and dosing that we use, especially following infection. With that, I'd like to thank my co-investigators, staff, trainees, funding agencies, other supporters, and the COVID Immunity Task Force for organizing this webinar and inviting me to speak.
Thank you very much, Dr. Grant. So there's a lot to ponder there. This is really tricky to try to understand how this can best inform our strategies going forward. So let's look now at who actually did Omicron affect most. This slide shows basically, the next slide shows basically what Dr. Buckridge had shown, that a group that started the pandemic with, obviously not affected at all, but has ended up with an infection-acquired immunity rate over 50% are young adults, those between 17 and 24 years, shown here in the light blue dots. And if we can move to the animation, we can see that kids under 17, shown here in the maroon dots, had very high infection rates, as any parent can attest. Next slide. Why were children and young adults so at risk of infection? Well, they are often in group settings such as schools or universities. They have broad social networks. Many have frontline service jobs, coffee shops, restaurants, retail. Their living situations can be in group settings or in dormitories. They have a lower, in general, perceived risk of COVID-19, and the social media may be playing a role there. They are more likely to have asymptomatic or mild disease, and therefore they may be less likely to get tested. And when they do test, they may not test positive with rapid tests. We also saw higher incidence of COVID-19 among lower income Canadians. Here you can see the comparison between the lowest quintile, so it's dividing the population into 5 groupings. This is the lowest 20% from the point of view of material deprivation, shown here in turquoise, and the highest quintile, shown here in black. Next slide. In fact, seroprevalence from infection has been higher among lower socioeconomic communities throughout the pandemic. For example, Montréal Nord, which is a community of lower socioeconomic status, had 12% compared to 5% for the rest of Montreal. In children, it was even higher, almost 17% in Montréal Nord, compared to 3% in the West Island, which is higher socioeconomic status. And the Statistics Canada household study found double the infection-acquired seroprevalence in multicultural, dense neighborhoods compared to high socioeconomic status urban settings. Again, we can ask, why are those in lower income neighborhoods more at risk? As we have all observed over the past 2 years, the pandemic has exposed long-standing structural and societal fault lines that were existing in our healthcare systems and in the inequities that are evident in many aspects of our society. These include multi-generational housing and high population densities, a reduced risk to self-isolate outside of work, as was the case for essential workers. People had children in daycare, and for everyone who had to rely on public transit. Working conditions created risk for many people who work in healthcare, for people at high risk of exposure who have inadequate personal protective equipment, and for all those with public-facing roles. The combination of the lack of sick leave and health benefits with insecure employment forced people who had been exposed or were infected to keep on working. Next slide. When we look at access to healthcare, we see that people in lower income neighborhoods had reduced access to COVID testing. Minority groups were disproportionately affected by chronic medical conditions like hypertension, diabetes, asthma, etc., that we know increased the risk of COVID complications. Many lacked a primary healthcare provider, and they may have been reluctant to seek care because of fear of racial bias and language barriers. And for a number of reasons, vaccine confidence was lower in lower socioeconomic status neighborhoods. For example, 11% of Montreal Nord residents said they were likely to not vaccinate versus only 4% for the rest of Montreal. So how can we prepare for the next wave that likely will come in the autumn? First, everybody needs to keep up to date on vaccines, even post-infection, as we've seen. The Omicron wave affected millions of people, and breakthrough infections in vaccinated individuals have generated hybrid immunity that Dr. Grant spoke about. Hybrid immunity helps protect against severe outcomes, but infection is not one size fits all. Variants offer different immune protection and duration. And as we saw, the severity of disease impacts your immune response. I want to emphasize here that data from task force funded studies and others around the world strongly suggest that vaccination, regardless of previous infection, is highly effective in preventing severe disease, including when infection is caused by variants such as Omicron, BA.1 and BA.2. Infection is not a viable strategy to achieve or maintain immunity. So forget going to some kind of COVID party. Don't. There remains a risk of severe disease and death. There's the threat of long COVID, which we don't know lots about, but it's obviously a concern, and we're seeing it increasingly in our communities. There's a possibility of spread of infection to others. And unlike vaccination, infection is not guaranteed to induce immunity. In fact, 1 in 8 infected individuals do not seroconvert following infection. And as some people who were infected by the BA.1 Omicron have already found, infection from one Omicron variant does not promise immunity against the next. So everyone is tired of this. But to prepare for the autumn, we need to continue to engage on the dangers of COVID-19. The pandemic is not over. The Omicron tsunami underscores our need to resist pandemic fatigue, get all the recommended vaccines, and respect public health efforts. Be smart. Mask up in crowded settings. Watch for poor ventilation. SARS-CoV-2 infection presents real risks. And as I've mentioned, the after effects of COVID, including long COVID, are still undetermined. SARS-CoV-2 can be transmitted to others who can get very sick and die. So we have to continue our public health measures even if they are no longer being mandated by provinces and territories. We need to use our common sense to protect ourselves and our loved ones from COVID-19. Again, be smart, mask up when it makes sense. What else can we do to prepare for the fall? We need to be clear about what up to date with vaccination means now, and we need to focus on increasing vaccine confidence. Vaccines have proven effective against severe disease and death from all variants of concern. We need to highlight to the population, we've done very well, we've achieved very high rates of vaccination, but we must evaluate immune protection in terms of severe disease and death, and not just the number of people infected. Those are the indicators we need to track. And we need to implement campaigns that are tailored. They're tailored to parents, they're tailored to young adults, to those in lower income areas, to racialized communities, in fact, to everyone, but tailored. Now, I do have questions. I've been watching them come in for the panel, but I also realize we have many questions coming in from the audience, and I certainly want to leave time for those. So we thought of these being kind of the issues we might want to look at. And I'm thinking we might answer the first discussion point here, and then we'll go to the question and answer period. So for everyone who has a question, now is a good time to put your questions in the Q&A section below if you haven't already, and we'll get to as many as we can. Si vous préférez poser votre question en français, allez-y.
If you prefer to ask your question in French, go ahead. There are a number of us who will be able to respond in the language of Molière.
What strategy should people use to decide when and whether to vaccinate? Another dose now, wait until the fall? How long should one wait after infection to get another dose? Does everyone need a booster? What vaccination strategy should public health adopt for the fall? So should it be tailored for priority populations? Should the strategies be by age grouping, say 5 to 17, 18 to 69, 70 plus? What should public messaging include in preparation? So moving away from this terminology of fully vaccinated to the idea of getting and staying up to date on vaccine protection, and the importance of smart, common sense assessments of risk of crowded, poorly ventilated settings, respect for those who wear and do not wear masks, and other things we might include in the public messaging. So panel members, let's start on the first discussion point here, and then we'll go to the question and answer period. So I'm going to ask Dr. Piccirillo first. You studied how Omicron escapes our immune system. You told us that Omicron infection induces weaker antibodies than other variants, but good T-cell responses. What do you think? Should people who have had Omicron wait until the fall to get their booster? What do you think?
You know, it's a great question, and I wish the answer was simple. I think there are many factors that should be guiding our decision. There is no question that vaccination and sustained boostering is essential for our long-lived immunity. But if one takes a look at the context at which we are in right now, the wave at the current time is tapering off. We are entering a festive barbecue season that will encourage all, if not most of us, to be in open outdoor settings. And considering the fact that the infections very likely also follows some kind of seasonal pattern, I'm tempted to say that vaccination right now probably would not have, a fourth booster right now would not have much of an effect. It would probably be more strategic to have a fourth booster administered, preferably with a variant adjusted vaccine, perhaps at the end of the summer, beginning of the next fall.
So that's great. And I think there's a lot of hope that there may be other vaccines coming down the pike. I don't know if they'll be here in time for us though. So Dr. Grant, you showed us that mild infections do not induce as strong an immune response as severe infections. And you showed that immunity seems to be functionally enhanced when it's hybrid, but that Omicron seems to give us an incomplete immune response. So I guess the question, should people who have had Omicron get their vaccines up to date for the fall? And should we actually factor in an infection when we define what up to date means for different age groups?
Well, again, you're asking incredibly difficult questions, but to the first one, absolutely, infections should be considered when you're determining whether somebody is up to date with their vaccinations. In every study so far, infection is at least equivalent to one dose of a vaccine. And in some conditions, certainly when it's a severe infection, it's inducing better immunity. I believe the focus should be, for the time being, should be on people who are vulnerable, getting a boost if they are going to be around people. It's a huge question for the fall, although I don't think we know yet what the vaccine is going to be. Will it be Omicron? Will it be a twin to Omicron vaccine? I think an important question that I'm not sure virologists have addressed yet is, do we need to worry about Wuhan, Delta, Alpha, and those viruses coming back in some form or another, or are they extinct? And what are we going to face in the fall? It's much more likely to be a subvariant related to Omicron, I think, than something more closely related to any of the ancestral strains. So there's a bit of a question for people who are vaccinated. They've had 3 vaccines in some cases, and then they've been infected with Omicron. What's the value going to be for a healthy young individual of getting a boost with an ancestral spike antigen that may not exist anymore? It'll boost your antibodies somewhat, but it certainly doesn't boost it selectively for Omicron and the new variants that we think are probably coming.
Okay, we've got tons of questions coming in from the audience. Audience, please stay in the language option that you prefer and enter your questions in the Q&A section if you haven't already done so. We'll do our best to answer those questions, as many as possible in the time remaining. So there have been several questions come in about long COVID. I can see, there's the fact that so many people got infected. So is that likely going to translate into a higher prevalence of post-COVID morbidity, long COVID, etc.? So there's that question about whether we're going to see more long COVID. And there's also a question about whether vaccines reduce the risk of long COVID. So who wants to talk about whether we're going to see more long COVID?
I am a volunteer. Honestly, I have no direct knowledge of long COVID and don't study it, but all the evidence so far is that yes, we are going to have more long COVID because of the much greater number of infections. It may not be as prevalent with Omicron as a mild infection as with some of the previous infections, but the overall number is so high that if it can cause long COVID, there will be more cases of long COVID than we have had in the past. People who are studying it give much better answer, but it's very early days. Things need to be defined. Is there, a question some people would have, is there a unique syndrome, a long COVID, or is it a reflection of the post-viral syndrome that is associated with flu and other viruses? So it really needs to be defined. Is it something unique? Is it something we've seen before? How will we deal with it?
Thank you, Dr.
We'll see more.
Thank you, Dr. Grant. I mean, I listened to an interesting podcast this week from the US suggesting 10 to 30% of people, like it's a huge range. have some kind of a post-COVID syndrome. So, and I think it's something that all of us are concerned about, you know, the long tail impact of this pandemic and what it means for people and what it means for social services and health services and for the economy and all of those kinds of things. So there's a lot. I do want to say one thing. There is a big study out in the field right now, and 100,000 households in Canada are being asked to participate in a survey of chronic symptoms, healthcare access. It includes a dried blood spot and a saliva specimen so that we can look to see what's the correlation with infection. And the goal is to see what comes up in terms of the potential of long COVID. What are we seeing? And it's being run by Statistics Canada. So if you're lucky enough to be chosen, do participate, please. Dr. Piccirillo, did you want to comment on long COVID, or should we move on for the questions that are addressed to you?
I was simply going to say that I would tend to agree with what Dr. Grant shared a few moments ago.
Okay, great.
Thank
so
you.
I would just add, if I can,
yeah,
Dr. Hankins, that, you know, I think Dr. Grant gave a great answer, and it's not the area of my study either, but I just wanted to point out that, you know, we did have a lot of infections with Omicron, but many of those were probably asymptomatic and quite mild. And so there does seem to be some relationship between severity of infection and post-COVID, from what I understand. And so, you know, I don't think we should interpret that number as the number of people necessarily that are going to necessarily, you know, have some kind of a long COVID syndrome. We have to recall that many of them were mild or asymptomatic entirely.
Thank you. That's an encouraging point. Dr. Piccirillo, there's a question. Are there differences in reinfection rates for Omicron versus other variants? I mean, we are seeing people who got Omicron, you know, in December, January and getting reinfected. I mean, what do you think?
I don't have the numbers offhand, but the answer is yes. Omicron is really the stealth-like virus that the reputation that we have given it, the mutations that it has acquired through its development, really procure it with extraordinary capabilities of escaping prior immune control, but its capacity to stick to cells, get into the cells, and to replicate in cells. So taking that into consideration, its genetic makeup has really influenced its personality. And its personality is to be extraordinarily contagious. And in that regard, the answer is yes. I just want to reiterate a point that you made, Dr. Hankins, in your presentation, and a point that Dr. Buckridge made a few moments ago. Not all infections elicit a protective immune response. You can be infected, you can be PCR positive, you can have a positive antigen test, but your adaptive immune response has not been tickled, that hasn't been activated. And so we need to make that distinction. But the reinfection rates are clearly quite observable and documented.
Thanks. So tickling the immune response, I like that. Dr. Grant, there was a question for you. What was the definition of mild versus moderate COVID in the data that you showed?
So mild infection was less than 3 symptoms for less than a week, and moderate was more than 3 symptoms for more than a week, and severe was hospitalization. Okay,
excellent. Okay, so Dr. Buckridge, here's a tricky one for you. Can you speculate on why Western Canada's infection rates are higher than the rest of the country?
Well, that is they clearly are, from what we're seeing, and so there's not much doubt in the data that we are seeing higher level of seropositivity, and certainly over the Omicron era, higher rates of infection. And you know, we know the things that influence your infection. One is, of course, vaccination, and we have seen lower vaccination uptake in some Western provinces, certainly, so that's a factor. The other is behavior, in terms of how people behave and the extent to which different what we call non-pharmaceutical interventions are put in place, which is how the health system or the government, you know, limits mobility, in terms of access to different public areas and requires mask wearing and so on. So it's probably a mixture, I think, of my guess is, and I have not seen any specific analyses on this, but we certainly have seen in other parts of the world when people look at factors like vaccination rate and the number and intensity of non-pharmaceutical interventions that are put into place, that those directly are related to both seroprevalence and the number of infections. And so if I had to hazard a guess, I would say it's because of differences in Western provinces, generally lower vaccine coverage, and probably differences in terms of behaviors in relation to non-pharmaceutical interventions put in place by the provincial governments.
Okay, thank you. A good answer to a somewhat tricky question. Okay, here's the question. Just looking at the presentations on the immunity that infection induces, what we've sort of seen, what can you say about waning of this immunity? Is it more likely to wane more quickly with this variant? Is there a physiological explanation for why? Can we understand a little bit better as to how long infection-acquired immunity lasts, thinking of the Omicron wave, and does it last as long as vaccine-induced immunity? Like, what do we know about how long you can go? Dr. Piccirillo, do you want to start with that?
It's a great question. I don't know if people have compared it side by side in terms of whether one is more long-lived than the other. But I do think that Omicron is comparable to one trying to start a campfire on a wet ground, where the capacity of the fire, the flames to initiate and to sustain itself is directly dependent on the level of humidity on the ground. So Omicron, because of its capacity to infect but not tickle appropriately to fully activate an immune response, to elicit those key antibody and protective T cells to clear it, may have something to do with it. But I defer to my colleague, Dr. Grant, who may have something in his own pipeline to discuss.
Well, I agree with all that. I would love to be able to look at the immunity in people who were unvaccinated and contracted Omicron, because there's no doubt that the level of response is related, level of immune response is related to the amount of antigen that you're exposed to and the amount of time that you're exposed to that antigen. So if the Omicron infections are incredibly mild, maybe because of the virus, maybe because of previous vaccination, then it's less able to tickle the immune system. But on its own, if it were to infect a naive person, maybe it would be enough in that case to tickle the immune system. But certainly we're in the situation now where with vaccinated people, they get Omicron, they don't make a very strong response directly against Omicron, and we're susceptible to reinfection because of that. But as long as it's mild, that's all right.
Be careful what you say, Dr. Grant.
Well, it doesn't really matter because, I think we've all seen people get their third vaccine and their fourth vaccine and then catch Omicron. So it's not just a matter of getting vaccinated. If you want to completely avoid any risk of infection, you have to get fully vaccinated, wear your mask, stay out of high-risk situations. It's great. The vaccines are great at protecting against severe disease, severe infection, but transmission is occurring in fully vaccinated individuals.
Exactly. So what can we say? None of us are vaccinologists on this call, but there's a question that's come in on the safety assessment of, like third, fourth, fifth plus doses. Like, is there any risk to getting many doses? Like hitting the immune system, hitting the spike over and over? I think, Dr. Grant, you mentioned, there's a difference between the vaccine formulations that are Wuhan virus inspired versus the kinds of variants we're seeing. But say we're talking about the same vaccines we've got, these mRNA vaccines we have now. What do you think? Is there any problem with getting additional doses? Yes, Chiro Pickering.
I'm just going to add the vaccines up until now, as you've indicated very nicely, are directed against the S glycoprotein. And it's an obvious target because it is the key that allows the virus to get into the locked cell. But we also know through experimental data in the literature that proteins, viral proteins outside of S, also elicit immune responses and contribute to the protective nature of that immune individual. So if we continuously give 20 doses, 50 doses of a booster that's exclusively directed against S, there could be, you are not harnessing the protective potential of immune responses against those non-S proteins. So I suspect that in the upcoming generations of vaccine formulations, perhaps not next fall, but in later phases, that we may be considering vaccine formulations that encompass a greater global representation of the viral proteins, A, and B, perhaps a different strategy in which we administer those vaccines. Up until now, all of our vaccines have been administered in our shoulder muscles. And so we're eliciting fantastic responses in peripheral blood. But how does that peripheral blood immune response translate in the lung where the virus enters? So that systemic versus local response is going to be very important for vaccines to achieve. So I suspect that the formulations, intramuscular versus intranasal formulations, will all contribute to our capacity to hone in our immune protection towards those viral components that are most important.
And you mentioned intranasal. I mean, there is an intranasal, I think, vaccination for influenza that adolescents often get, or children get. So we've got, the concept is there, and it makes a lot of sense because this is a virus that's entering mucosally. You know, it's so it makes sense to move in that direction. There's a question here about, is the original Wuhan strain no longer active? Will we continue to see new variants? I think one of the things that's really striking when I look at it is that, you know, the variants of concern we have seen, they're not riffing off each other. You know, they are independently being created in different settings. So we can see perhaps, you know, Omicron might evolve a bit more, but, you know, there's always this risk of pi or whatever we're going to call the next variant showing up. So Michael, what do you think? I mean, have we got any Wuhan circulating still in different populations, or have we really moved on with the Delta wave?
As far as I know, we've moved on, and we keep being surprised. It's amazing. The infectiousness, the contagiousness of Omicron is really amazing. And to think that there could be a variant evolving that would be even more contagious, more infectious is hard to fathom, but it's certainly possible. It's speculation, but I don't think we'll be going back to Wuhan or Delta or Alpha or any of those viruses will be able to reemerge and get a new foothold in the population. So I suspect it'll be some subvariant related to Omicron that we need to deal with in the future.
So we don't really have a crystal ball. But we do know that this is not over. And so we need to anticipate and prepare as best we can. So Harriet Ware, I wanted to ask you, just looking at what we're seeing, you know, we saw in South Africa, the rise of the BA.4 and the BA.5 variants. And, you know, see these moving up into Europe. And now we're seeing, if you look at what's going on in Canada, you can see they're forming an increasing proportion of the sequences that are being detected. Can you, in the Zero Tracker work, do you get a feel for how these are moving around the world from region to region?
Great question. So, yeah, unfortunately with zero prevalence studies, typically we don't have the variant because we're just looking for potentially an indicator of past infection. But we also do usually complement our data with GISAID, which where genomic sequencing is conducted regularly. And so, yeah, through that, we do get a sense of how the variants are moving. I don't have the specific data, but yeah, I believe that's correct about the BA4 and 5 starting to move through.
Thanks. So trying to anticipate, there's also a question in here, there are some kind of assumptions we have in our head that this is going to be seasonal. It's going to act like the flu and so on and so forth. And we've got all kinds of different things going on. We're seeing a lot of respiratory viruses right now, but normally we wouldn't be seeing in June because people have not been exposed to them over the last 2 years. We're seeing quite an intense flu pandemic or flu season in the Southern Hemisphere, in Australia and so on. We're acting like, Dr. Petrillo, you talked about it, it's barbecue season, we're going to be outside. We're acting as though this is seasonal and we don't have to worry until the fall. Is that, are we okay with that? Can we have a good summer? Dr. Petrillo.
I wish I had the crystal ball that you were referring to a few moments ago. I don't have clear answer to that. I refer to the seasonality based on our historical understanding of many respiratory infections. But you've illustrated very nicely in the last minute of how that understanding has been distorted through epidemiological evidence around the world. My intuition, scientific intuition, based on facts, is considering the slope of this curve, considering the fact that our population has been largely vaccinated, perhaps not fully, but en route towards an updated ongoing vaccination scheme, considering the very high prevalence of Omicron in our population, as Dr. Buckridge indicated in his presentation, 40, 50 in our province in Quebec. I believe the word 60% resonated in the media at some point. Considering the outdoor nature, I'm assuming that the chances of viral transmission are reduced. And so that's really my only hunch. And as we enter the next fall season, where we are back indoors and possibly exposed to a sublineage of Omicron, that's my hypothesis as well. I would tend to agree with Dr. Grant as well, with the unknown balance between, is it going to be more infectious and or more virulent? These two is a tug of war. And usually when viral evolution goes towards infectivity, as is the case for Omicron, it's like pulling the blanket. It's at the detriment of virulence. Historically, I may be wrong for Omicron, but that's a sentiment that I have. Yeah.
Okay, thanks. I won't ask you all to say what kind of summers you're going to have or you're predicting you're going to have, but let's hope we do have a good one. There is a tricky question we need to address. So this is the one we've watched in the US. The FDA and CDC has now come out, approving vaccines for that 6 months to age 5 group. They have a relatively low absolute risk of severe disease. And we've seen they have high infection-induced seroprevalence. So what is your assessment of the incremental benefit for immediate vaccination with an ancestral strain variant in this population? I'm going to throw this to you, Dr. Grant. This is a tricky one because we don't know yet, what the decisions are going to be in Canada, et cetera. And we know, there are many, many parents who've been waiting for this, and there are many other parents who've said, no, I'm not going to do this. So Dr. Grant, your microphone is off.
Thanks. Well, I think I know what public health recommendations are going to be for vaccination, but I honestly believe that this is a decision that parents have to make as informed consumers. And for the reasons that you just mentioned, there's a very small chance. The vaccines are safe, no problem there, but there's a very small chance that the children between 6 months of age and 5 years of age are going to develop severe infection from Omicron especially. And it's going to be a decision that parents have to make, whether they feel the risk from infection with the virus that's circulating is more severe than allowing the child to get infected and develop a form of immunity that might be better for the child in the long run. We didn't really get into some of the potential risks from the continued vaccination or a repeated vaccination. And at this point, they're largely theoretical, but it's been seen with the flu vaccines. There's problems with imprinting, original antigenic sin. And it's going to be a tough decision for parents, but it's really something that parents are going to have to inform themselves as best they can and make the decision as best they can.
So Dr. Piccirillo, you put your arm up. Are you going to explain imprinting and original antigenic sin?
No, I was just gonna, Dr. Grant is inspiring ideas and thoughts in me. Clearly the children per se are not at risk themselves. We've known this since the beginning of the pandemic. So vaccination to induce a little more protection in them may be useful, but I simply want to emphasize that despite the vaccination of the child, they can still be infected and carriers of the virus and propagators of the virus. And I think that's an element that we need to embrace as a society. If a child that's in high contact areas is living with their grandmother who has a pre-existing condition and who is at risk, perhaps the parents of that child will take the judicious decision of saying, you know what, the child is not more at risk, but is at risk of transmitting a variant to an elderly grandmother with pre-existing condition X. So it's really context dependent factors which only the parent have to evaluate. Thus the importance for our global scientific community to educate, to sensitize, to embrace these factors.
Thank you. That's really helpful. And I think it's worthwhile looking at the clinical profile. I mean, the data that we hear on the radio and on television are from the US on the number of kids who've died and so on and so forth. I think it'll help parents do that risk benefit assessment if we can look at what has been the experience in Canada. Where does this now fit? Now we're expecting the National Advisory Committee on Immunization to decide in July what their recommendation might be. It still has to go through Health Canada approval. So, this is not an urgent, immediate kind of decision, but it may be the kind of thing that gets discussed over those summer barbecues you're talking about. David, did you want to comment at all on this 6 months to 5 year, or on maybe getting the second dose in the people that got one dose in the 5 to 11 group?
Well, I don't know if I can really get into the specifics on that, but I would just add, I think that, this question of vaccination for children is really an interesting one. And there is some evidence that we can look at other respiratory conditions like influenza. We tend to take which I think is, for the most part, the appropriate perspective that Dr. Piccirillo took of the individual decision-making perspective, in terms of risks and benefits for the child and the people around that child and the family. There is another dynamic going on at the population level, though. In influenza, we've certainly seen that children tend to shed more of that vaccine, or that virus, sorry, and so they tend to be, even though younger children don't get often very young children get severe cases, but, younger children, adolescents, not so much. But they're really important in the spread at a population scale for all the reasons that we've discussed, numbers of contacts, their social networks, that kind of thing. And so it has been shown that if, extending vaccination to younger age groups in that context, there's some evidence to suggest that will decreased, in fact, the overall rate of spread in the population. So this is the interesting thing about vaccines, is that there's a very individual perspective on them, and there's also kind of more of a population perspective. And so I think this is a bit of the challenge, is that, of course, parents are the ultimate deciders here and have to make the decision for their children, what's the risk benefit ratio. But there may be a benefit to vaccinating children that extends beyond individual children, kind of like Dr. Picciarello said, but going beyond that individual situation, think about that, what that means at scale. They can be actually important in the sense of almost kind of creating a fire break, if you will, for the spread of the pandemic.
This is an important point because there have been a number of household transmission studies that show that vaccinated people who get infected are about half as likely to transmit to somebody else in the household. So it may be something to do with the viral load that you get if you're infected, but you're already vaccinated. Again, more questions for us to answer. I think we're starting to come up to the end. I'm just thinking, I've got some things I need to do. I need to thank people and so on. So maybe I can close the Q&A session. It's been great. And there are many more questions, and we will try to get to people who pose questions. We'll try to answer those questions even after the webinar. So I have a few brief announcements. First of all, I want to thank all of our presenters today, Dr. David Buckridge, Ms. Harriet Ware, Dr. Ciro Piccirillo, and Dr. Michael Grant. Thank you for your research and for your expertise and for your time today. And I'd of course like to thank all of our attendees. Thank you for sharing your time with us today. You sent in lots of great questions, and I hope that you have learned something new. So our next event in this series, so we're not done, so if you can put up a slide on that, will be in September. So please stay tuned for more information. The COVID Immunity Task Force team will be preparing a summary of this webinar, of this seminar, and we'll make it available as usual on our website. So if you came in late or you had to leave early, you can watch it again on the website. We will also post a recording of this seminar, and the presentation itself is already on the website as a PDF. In case you'd like to see it, to go back and look at one of the slides or to share it. If you receive our weekly newsletter, you will get informed as to when everything is up on the page. And if you don't receive our newsletter yet, and you would like to, please go to our website's homepage and sign up at the bottom. So that's all for today. I invite you to stay abreast of all of our results by following us on social media. Thank you again for joining us, and take care, everybody. Goodbye.